Welcome to Golden Hour Health and Safety, where we discuss pre-hospital information geared towards EMRs, EMTs, and paramedics of different levels. Today's lesson, we're going to be talking about acetylsalicylic acid, or otherwise known as ASA. Now that's quite a tongue twister. So generally in medicine and in healthcare, we actually refer to acetylsalicylic acid as ASA. So through this video, that's what we're going to be calling it. A quick disclaimer before we begin. This is for information only, and this does not replace your local training, protocols, new information, or research, and is not intended for those not working in, towards, or involved in healthcare. Please always follow your local protocol as well as your own scope of practice. So as we mentioned before, acetylsalicylic acid is also known as ASA and is commonly sold under the name aspirin. It is also a non-steroidal anti-inflammatory drug, or an NSAID. ASA is excellent at relieving mild to moderate pain and can help reduce a fever. It can also protect against thrombotic disorders and can help in other inflammatory conditions. However, ASA can cause gastric ulcers in a patient who's been chronically taking ASA for a long period of time. So the mechanism of action for ASA is that it is a non-selective inhibitor of COX-2 or cyclooxygenase. And this is really a huge benefit in regards to the treatment of acute coronary syndromes like myocardial infarctions and angina. And in pre-hospital setting, we don't use it typically for ischemic strokes. However, there are many patients that take ASA to prevent ischemic strokes, and in the hospital, some physicians do choose to use it. Again, in pre-hospital setting as paramedics or EMTs or otherwise, we tend not to use it for that purpose. ASA is also an irreversible inhibitor. So the inhibition of COX-2 will last until the tissues have synthesized new cyclooxygenase. So ASA is readily absorbed and widely distributed through the body when taken orally and chewed. This does include all the tissues, breast milk, central nervous system, even fetal tissues, so it is widely spread throughout. Now, the small intestine is the principal site of absorption. That's why we do need to chew it up to make it as small particles as possible so that it can be digested as quickly as possible. ASA also has a short half-life, about 2 to 3 hours, when we're using it at a low therapeutic dose. Now, at high therapeutic dose, the half-life could certainly last longer, even over 20 hours. But in the emergency setting, we're typically using about 160 milligrams. So let's now talk about some adverse effects of ASA. So one of them is our gastric distress. So this can have the patient complaining of constipation, bloating, nausea, vomiting, abdominal pain, that sort of thing, as well as occult gastrointestinal bleeding, which is defined as gastrointestinal bleeding that is not visible to the patient or the physician. We also just have the increased ability for the body to bleed, as ASA does inhibit the platelet aggregation, acute renal impairment, which is retention of salt and water and can cause edema, hypersensitivity, most common in those with a history of asthma and rhinitis, and lastly Reye's syndrome, which is oddly very rare, but it is a childhood syndrome, so that's why ASA is contraindicated in children. Just like any other drug, ASA does have drug-to-drug interactions. So the first one would be our anticoagulants. ASA can amplify the effects of other anticoagulants such as heparin and warfarin. So in the emergent setting, we're not super concerned with that, but in long-term care, it's definitely something that we need to be cognizant about. The next one would be our glucocorticoids. Glucocorticoids also promote gastric ulcerations, just like ASA does. So a lot of times, over a long period of time, we don't use them together, or other medications need to be used in conjunction. The use of alcohol and ASA can definitely increase bleeding. When other NSAIDs are used with ASA, For example, naproxen, ibuprofen, these can block access of ASA to that COX-1 in the platelets, making ASA less effective. Then we have our ACE inhibitors, which are our angiotensin converting enzymes and our angiotensin receptor blockers, or ARBs. And these can also impair the renal function just like ASA. So high doses of ASA should be avoided, especially over long periods of time. Lastly, we've got vaccines. So NSAIDs of all shapes and sizes can blunt immune responses to a vaccine. Now, again, all these interactions in the emergent setting is not something we as medics are necessarily concerned about. But if you are going to use a medication with a patient's condition, it is a good idea to know what it does and the interactions that it has. Okay, now I just want to preface this next section with a warning. Always follow your local protocols within your scope of practice. This is not a replacement for that, and this is also not a replacement for official approved training, and it does not replace any of that. So just keep that in mind. So in emergency services, the indications to use ASA is what we call suspected acute coronary syndrome, or ACS. It's the most common use, especially for paramedics emergency services. And this is because it inhibits the platelet aggregation, preventing the formation of thromboxane A2. The most common contraindications before you use ASA would be a patient who has an allergy, hypersensitivity to ASA or other NSAIDs, have an active gastrointestinal bleed, or are asthmatic patients who have a known sensitivity to NSAIDs or to ASA. The following is a common dosing for adult patients having a suspected acute coronary syndrome, or ACS. ASA is again not recommended in children due to Reye syndrome. The adult dose that we commonly see is 160 milligrams PO, or orally, and the patient needs to chew this medication up. And typically the total maximum dose is 160 milligrams within 24 hours. Lastly, a quick note. If the patient states they took ASA prior to your arrival, it is generally recommended to still administer your ASA as described, as it's really hard to tell if the patient did or did not. Did they take the right dose? Did they get acetaminophen mixed up with ASA? So it's a good idea to just go ahead with your dosing. However, in saying that, if the patient took ASA prior to your arrival on the advice of other emergency medical services direction, and you can confirm that, you can withhold further ASA. And again, this is dependent on your skill, your scope of practice, and your protocols where you work, but that's very common in the emergency services setting. Okay, so that concludes our lesson for the day. Thank you, and we appreciate the time you've committed to your education. We would love to hear from you, so give us your feedback, put a comment down below, send us an email. If there's a certain topic you'd like us to discuss in the future, we'd love to know about it.